Good morning, ladies and gentlemen, to those joining us in Brazil, and good afternoon to colleagues in the UK. This is Adam Patterson, Deputy Director for Britcham Paraná, and it's great to be here with you all today for another brilliant Britcham webinar. And what a talk we have for you today with representatives from the world-renowned Turing Institute, the UK's National Institute for Data Science and Artificial Intelligence. Today, we will discuss health data equity in Latin America in the age of AI and genomics. But first things first, our heartfelt thanks to Britcham supporting members whose brands were widely publicized on the opening slide of this webinar, to Leonardo Trench, Regional Director of Britcham Paraná for the partnership, to Luciano Moraes and Luis Felipe de César, President and Vice President of the Technology and Innovation Committee, and to Andrea Splendor, President of the Health Committee, for co-organizing this event. And of course, thanks to everyone in the audience tuning in. And last but certainly not least, thanks to today's speaker, Dr. Manuel Corpas, Fellow of the Alan Turing Institute, for sharing your knowledge and insights with our audience today. The British Chamber of Commerce and Industry in Brazil, Britcham, has been operating in Brazil for almost 110 years, being the most relevant forum of the Brazil-UK business and government community to increase trade, investment services and bilateral relationships. We operate nationally in Brazil with branches in Paraná, São Paulo, Rio de Janeiro and Minas Gerais. We bring together in the Chamber major British investors in Brazil from the most diverse sectors of the economy, as well as Brazilian companies that engage in UK-Brazil relations. The Chamber operates through 13 thematic committees, including agribusiness, human capital and education, international trade and investments, defense and security, economy and finance, energy infrastructure, legal tax and regulatory subjects, health, risk and insurance, technology and innovation, and also the Consultative Advocacy Commission on priority issues on the climate, tax and regulatory agendas. This year, we've already had some great initiatives carried out, including in-person events, webinars, lunch lectures, technical visits, seminars, meetings of CEOs with public authorities, amongst many other initiatives. All the activities we carry out follow and reinforce Britcham's mission to promote bilateral business between Brazil and the United Kingdom, serving members and contributing to the growth of trade, industry, services and investments. In due course, one invites everyone to visit Britcham's website, www.britcham.com.br, and participate in the Chamber's next events. Now, with that being said, and without much further ado, to present today's speaker, I will now pass the floor to Luciano Moraes, President of the Technology and Innovation Committee, to kick off today's talk. Thank you very much, Luciano.
Thank you, Adam, for the opening remarks, and thanking to Luis Felipe de César, for the partnership and the Technology and Innovation Committee. So I'd like to share a couple of instructions about today's webinar, right? So today we are being streamed this through Zoom and YouTube, right? The speaker's presentation is going to be followed by a Q&A session. In the Q&A session, right, the questions can be sent through the Q&A tool in the Zoom platform. For every session, right, we need, please, that whomever is raising the question should provide the name and the company, right? So we can identify who is talking and address the questions in the proper way. And obviously, we'll get all the questions going through the Q&A tool, and there'll be like running a curation for the questions to be asked to make sure that we can combine some of them and be more efficient and effective, talking about the time we have to cover today, right? And in advance, we do apologize if eventually a question could not be addressed today due to time constraints. And I would like to then present our speaker. So it's an honor to have today Dr. Manuel Corpas. He's a senior lecturer in genomics and the course leader of the MSc in Artificial Intelligence and Digital Health at the University of Westminster. He's also a fellow of the Alan Turing Institute, the UK's National Institute for Data Science and Artificial Intelligence. With more than 2 decades of experience at the intersection of genomics, AI, and health data, Dr. Corpas has led pioneering projects in biobank scale data science, precision medicine, and the equitable use of genomic information, particularly in underrepresented populations for Latin America. He has authored over 80 peer-reviewed publications, contributed to international policy initiatives, and is widely recognized for his leadership in advancing health equity in genomics and digital health innovation. So, Dr. Manuel Corpas, the floor is yours.
Thanks so much, Luciano, and thank you for the great opportunity to share this morning or this afternoon with you. Hopefully you can see my slides now. If you can give me a thumbs up. Yeah, I'm assuming I can't see your, okay, cool, thanks. So I'm going to give you a little bit of the current understanding of how data representation really in general is actually affecting our understanding of health in general, not just in Latin America, but worldwide. But I'm going to give you a very sort of Latin American focused perspective on some of the current challenges and opportunities in terms of health data and how this is actually having tremendous implications in our next generation of artificial intelligence applied advancements for better precision in our diagnosis and treatments. But first of all, let me just introduce you to Yara. So she's a 10-year-old girl from a small Ticuna community deep in the Peruvian Amazon, near the borders with Colombia and Brazil. Her village can only be reached by the river, and the nearest hospital is 2 days away by boat. From the age of 6, Yara began to lose her hearing and balance. Her parents visited health posts along the Amazon River, but no one could explain what was happening. Eventually, a missionary doctor referred her to a hospital in Iquitos, Peru, where she was enrolled in a pilot program for genomic testing. Her DNA was sequenced, but the report came back as no finding. The algorithms that scanned her DNA had no reference data information because no indigenous Amazonian genome exists in the reference data that doctors use to diagnose diseases. And this is because all these algorithms mostly are based on data coming from European populations and North American samples. So the genetic change that caused Yara's condition had not been characterized, and her family went home with nothing but more questions. Months later, researchers collaborating with indigenous populations began sequencing local communities across the Loreto and Amazonas region. When Yara's data were reanalyzed against these new regional genomes, the change causing her disease appeared immediately. And it was a mutation which is common among Amazonian families, linked to a treatable metabolic disorder. So with basic medication, her hearing stabilized and her dizziness stopped. So the science hadn't failed Yara, but the data had. And as you can see, Yara's story is not just about one girl, it's about entire indigenous populations whose genomes, languages, and health realities are invisible to the systems shaping modern medicine. And as artificial intelligence and genomics become ever more prevalent in our treatment of patients, we have to ask, whose knowledge do our models learn from, and whose do they leave behind? For Latin America, the answer lies in partnership. Building data infrastructures that represent indigenous sovereignty, include local knowledge, and make health innovation a shared benefit, not an important privilege. Because if Yara's DNA had been visible from the start, her story would have been measured in months and not years. And that is what health data equity truly means. What I'm going to present throughout the rest of my presentation is where we are at in terms of current representation of people's data that then is used for their own benefit. So if we try to really justify why equity matters in health data, and by equity, I mean our ability to diagnose people with the same precision, irrespective of who they are, where they come from, right? We know that AI and genomics are transforming care, but the data behind excludes most of humanity. In fact, less than 2% of all the data that we have in genetics and genomics. Remember that genomics is basically all of the genetic data in one's organism, in one's body. So we use the algorithms to predict diseases based on the data that we have. And currently, less than 2% of all the genomic data that we have comes from Latin America. And that means that we have biased data that lead to biased models and therefore unequal health outcomes, with models that favor precision for those who are represented, that is European descent, versus those who are unserved and underrepresented. And this is because the development of the technologies and the access to these technologies have been mostly happening in Europe and North America. If we look at the first paper, the first research that looks into the representation of genetic data available in resources, as I said, these resources are then used as reference to help build models that predict diagnosis. In 2009, 96% of all the data that we had for representing complex genetic diseases, that is the diseases that people die of, such as Alzheimer's, diabetes, cardiovascular disease, metabolic diseases. So 96% of all the data that we had for those diseases that then are used for building models were based on European in 2009. In 2016, it got a little bit better, and we got 81% of all the data only as European ancestry. And you would have expected that as time passes by, that we would have been addressing this discrepancy in terms of the representation of data from different regions from around the world. But actually, that's not what's happened. And if we are comparing the amount of data that we have for building models that predict risk of complex diseases using genomic data, you see that the increase of European samples has exponentially increased. And you can see then how that compares to the actual share of the global population. So we have more than 90 or around 90% of all the data that is European, whereas less than 20% of all the data of all populations in the world are European. So we have clearly a very skewed and biased representation of the data that then helps us diagnose rare and complex genetic disorders. And we can see here the representation of the different countries. And it's not that sort of hard to miss that we have severe underrepresentation in Africa and Latin America, the global south, basically. And if we then look at how the actual representation in terms of all of the known genetic variation that exists, in other words, if we're able to quantify the genetic diversity that we know of, we actually see that there's more genetic diversity in Africa than any other region from around the world. We also see that what is called Hispanic or Latin America has a tremendous amount of diversity compared to the actual share of the global population. So we calculate there's around 8% of the global population that is Latin American, whereas the total expected diversity of genetics in Latin American populations is around 16%. So as you can see, there's a lot of diversity compared to their actual share of the global population, which is telling us that there's a lot of potential understanding and biological adaptations to the specific environments of Latin America that are potentially useful for our understanding of genetics and disease. If we then look at actual breakdown of the different populations within Latin America, I bring your attention, for instance, to Brazil here. So we see that around 15% of the Brazilian population could be categorized as Indigenous American. By Indigenous American, we mean people that are of origin from before settlers came from Europe and other parts of the world. We also see a very strong African representation within Brazil. Around 20% could be considered of African descent, and the rest European. But the problem that we have in terms of categorizing the diversity of genetic data is that, you know, we call all of these Latin American, whereas in fact, if we look at the composition, Latin America contains a huge diversity of different ancestral populations, some European, some indigenous, some African, and all of these different populations are going to have different susceptibilities. They're going to have different specific health attributes that if we are not able to properly characterize, then we're going to have very, very imprecise models for prediction and diagnosis of diseases. So why does this data diversity matter? It's because if we have models that lack diversity, then we're going to have less capacity to be able to have a better representation, a better way for implementing the latest advancements that we have, which are mostly data-driven. Also, this diverse representation helps us really then be able to use references that are then used by hospitals, for instance, to allow, for instance, to compare whether a particular illness has been observed and so on. So the diversity really helps have a much better diagnosis and treatment. And if we have a lack of representation, then those populations that are underserved, they're not going to get the benefit that other populations do get. Let me give you an example. So there's something called pharmacogenomics. So pharmacogenomics is the science that helps us predict, based on the genetic data, your likelihood for metabolizing a drug. So we know that depending on your genetic composition, some drugs are going to work better for you than other drugs. So there's a database called PharmGKB that collects all of the gene-drug reactions that have been to date understood and characterized. And if we then look at the contents of the different regions for which these data resource contains data, we have different regions that they sort of generate. So they call one region is American, and this American really refers to Native American origin. We also have what we call mixed populations, like for instance Latino or African Americans, and then we have other sort of subdivisions from around the world. If we actually look at the proportions of the information that we have between gene and drug reactions, then we see again that the European component of the data, which then we use to predict really adverse drug reactions, is mostly based on Europeans. And that's a big issue. And also we see that the data that we have for what they call Latinos and indigenous Americans is almost non-existent. And this is again, this is a huge issue, because if we are not able to have reference data for these populations, then our ability to predict whether a particular drug is going to be or is going to cause adverse reactions or not is severely handicapped. So if we then compare the proportion of underrepresentation, we actually see that Central and South Asians, so Bangladesh, Pakistan, and India, would be the most underrepresented. If we used this as the metric for underrepresentation, but this is not necessarily the case. We have that there are around 2 billion people who are Central or South Asian, and around 2% of all of the data that we have for pharmacogenomics is actually present. But you can see here, for instance, that Latinos, there's an underrepresentation of 7.8. This means that if we were to compare the share of the global populations versus the proportion of the total data that we have, then Central and South Asians would be the least well represented. The problem is, however, is that there's different amount of variation between different regions. In other words, as we saw earlier, the African populations are the most genetically diverse populations. And even being able to compare proportional share of the population against the actual representation in databases is a very poor measurement for understanding really the need for diversity. So in other words, if we compare exact representation in a database versus the global share of the population, that's a very poor way of measuring the diversity and the need for representation. If we looked, for instance, at clinical trials, in this case, these are all the drugs that were developed by the FDA, the Federal Drug Administration, the Food and Drug Administration from the US, which is mostly the biggest sort of agency for approval of drugs. We see that between, this is basically the last report that we've had access to. So for between the years 2015 and 2019, 76% of all the drug trials, all the clinical trials were developed in Europeans, only around 11% Asian and 7% African or African American, and 6% other. When I see this breakdown, actually, it makes me really worried, because, you know, that 6%, that includes Oceanian, includes Latinos, includes everything else. And the other thing I want to mention here is that depending on what resource you look at, some people make populations or assign labels depending on regions, and it's very, very difficult to actually have interoperability between the different resources. In other words, the sort of labels and the classifications of populations that different data resources use is not interoperable. It's very different. So here, for instance, they include, the north of Africa, they include them and classify them as Near Eastern. Whereas here, African or African American, they group them together. And then Asian, here we have East Asians, South Asians, all in one sort of group. So it's very, very difficult to compare the representation of data depending on which resource, because every resource have their own standard for classifying populations. And that actually makes it even more difficult to be able to understand how well represented the different populations from around the world are. Then if we look, for instance, at how much the proportion of people who are doing research in my field, most people are identified as male. If we also look at where people are doing this kind of research, you see that most people doing this kind of research are based in Anglo countries. So in other words, US, UK, and Australia. So that's really a big problem. If we also look at who's benefiting from genetic tests, you may have seen in the past, there are companies, one of them called 23andMe. You basically spit in a tube, pay $100, and then they give you a nice report where they say, oh, we give you some sort of health report, an ancestry report, and so on. We looked at a database of open access 23andMe profiles from individuals, and then we interpolated their likely ancestry. Our database was around 2,200 individuals, and then what it was really clear here is the vast majority of data is coming from people of European descent. In other words, the people who are actually accessing the genetic tests that are direct to consumer are overwhelmingly of European origin. And this is obviously very worrying because, again, this is a sort of signature of who is actually accessing these latest advancements. And it's not just a question of the fact that the tests themselves have been trained using European data. It's also the fact that if you're going to do these kind of tests outside of Europe or North America, either they don't ship these tests there, or if they ship, the data that they're going to be used as reference is biased towards the US, American, and European-centric genetic markers. And as we have seen in the previous slides, the genetics that you have is going to condition differently your ability to metabolize drugs, your disease risks, and the models that are used for predicting treatments. So this is a very, very important problem. Now, how is this actually affecting Latin American communities? So as I said, our ability to stratify high-risk individuals is severely compromised, and the research studies that actually include underrepresented populations from, let's say, indigenous population in Latin America, sometimes scientists decide to discard them because rather than helping them find results, actually they add noise. And we've seen situations where we have experiments that they say, well, let's just analyze and develop models on white British because, they are the most represented, and the other ones, we don't have enough because there's low number, and then that doesn't provide statistical power. So our analysis is not just in many occasions, without even realizing, is not biased, but it's actually entrenching and perpetuating the existing differences because of the sort of structural biases that exist. And of course, what this means is that the associated medical practices and the findings that we see in the literature are benefiting and representing only a very small subset of individuals. So the further you go from Northern European ancestry, the less precise the models are going to operate. But if we look, for instance, at the different populations in Latin America, we see that as I said earlier, the representation of different ancestries is very varied. We see that modern Brazil, for instance, have very different amounts of Native American ancestry depending on the region, and that has tremendous implications. If we look, for instance, at the breakdown of indigenous peoples of South America, interestingly, we have Peru that has almost 6 million indigenous peoples living there. Brazil has 1.7 million. If we then look at the native component, as we saw earlier, that depends on the country. So even though we group together all of the different countries and we call them LATAM or Latin American, actually we're going to have very, very different ancestries within the same country. And so depending on where you are, the same guidelines do not necessarily apply, right? So depending on the geographical location and the type of ancestry, you're going to have different guidelines because these guidelines are going to be different depending on your ancestry. But the problem is, as I said, is that things that work for Europeans do not necessarily work for indigenous populations. You see here, for instance, the number of indigenous groups in Brazil. Brazil currently has more than 200 different populations in terms of indigenous populations, and this is a huge amount of diversity that still remains to be characterized. And this is not just sort of useful in terms of having more personalized and more effective treatments and therapies. These are populations that have been for a huge number of thousands of years exposed to their own environmental stimuli, and that has led to, for instance, adaptations to malaria or adaptations to specific diseases that could be useful for us in terms of understanding the genetic component of these adaptations, which will allow us to have much better and more complete models for then representing the actual biology of our individuals that we study. But this is not just relevant to Latin America. I mean, if we look at London, for instance, the Latin American diaspora has grown 400% in the past 2 decades. So it's a diaspora that is not only silenced in a way, more than 40% has been reported to experience workplace abuse and exploitation. And more than 10 times than the average British person has been, who is Latin American origin, by 11% of the total, whereas the 1% only on average people of British origin feel being paid below the minimum wage. 11% of Latin Americans are being paid below the minimum wage, which is 10 times the average. So they are no longer invisible, the Latin American community in London and in the UK. And so the issue is, though, that although there have been very strong initiatives, for instance, trying to develop databases with the Pakistani and Bangladeshi British people, that hasn't happened yet. And when we look at data resources of reference from around the world, we see that there is a clear gap in Latin America, where the sort of what we call biobanks, that is a collection of data resources that can be used by scientists in order to perform research so that we can then understand the specific intricacies of these regions, they remain severely underrepresented or non-existent in the Latin American region. We really need biobanks because these data resources allow us to identify the genetic, environmental, and social factors that influence health and disease. The UK is pioneering in terms of the production of data resources that are being used for research analysis. For instance, we have the UK Biobank, which is the most important biomedical research resource from around the world. It has 500,000 individuals that have been completely characterized from a genetic perspective. And last time I counted, the UK Biobank had around 14,000 different measurements, health measurements, for those 500,000 individuals, which is something which is absolutely unheard of. It doesn't exist anywhere else. And in my opinion, is one of the greatest strengths that the UK has to offer the rest of the world. The type of measurements that are included in the UK Biobank have, for instance, physical measure, lifestyle questionnaires, imaging, chemical markers, surveys, physical activity, genetics. So having a resource that is standardized, that has sufficient power to include enough individuals so that we can statistically analyze is the key for us to be able to move on into the medicine of the future. And as I said earlier, unfortunately, what happens is that the most important global biobanks that you can see here, one of them is the UK Biobank. Another one that is very interesting is the Million Veteran Program, which is part of the US military system, where they have basically a million individuals. Also Finland with FinGen, all of us, which is another US database, and the Estonian Biobank. So these are the research data resources that are really contributing the most to the global knowledge of diseases. But then if we rank those diseases according to World Health Organization needs, we see that the top most important diseases that are affecting the global population are not, some of them are completely neglected, and they are neglected because they are not of interest for the global north, who is the region of the world that is really developing the data resources that are going to allow it to have the number of research papers, which is what we are measuring here. We can see that for stroke, in the past 20 years, we've had 1,056 research papers for stroke derived from the UK Biobank, Alzheimer's disease, 662, and so on. So you can see that in terms of research outputs, the amount of research that is being produced by the global sort of network of researchers doesn't correspond necessarily with the greatest need of the global south, with many diseases such as malaria, diarrheal diseases, neglected tropical diseases, or tuberculosis that are severely neglected simply because they are not that important for the data resources that are being developed mostly in the global north. So we see that even though the UK Biobank is the most important global data resource, still it doesn't really cover all the possible gaps that exist in terms of disability adjusted life years, which are measurements coming from the World Health Organization in terms of basically health needs. So what this means really is that the models that are used by AI are as fair as the data they are trained on. And when we have less than 2% of the global data that comes from Latin America, then every downstream model, from diagnosis to classifiers to drug response and predictors, are going to inherit that skew. So we are not going to have precise models for representation in those regions and populations that are missing. And if algorithms are trained on Eurocentric databases, then that means that they will systematically mispredict risk, drug efficacy, and disease prevalence for populations like those that exist in Brazil, which is incredibly varied, as we have seen. What this means as well is that underrepresentation is leading to misdiagnosis, where an AI model that is predicting genetic risk for diabetes or cancer may classify Brazilian or indigenous variants as unknown, as we have seen in our first slide with Yara, leading to false reassurance or delayed treatment. So if the model has never seen your data, it won't diagnose you accurately. And what this means is that these models, these biases, waste money, and drug discovery pipelines or clinical trial recruitment are built on incomplete data that misallocate billions by excluding viable patient cohorts from the global south. That's why having equal representation means having greater efficiency in terms of the healthcare that we're able to provide. This also means that we have missed opportunities for innovation, where Latin American diversity, even though it's an incredible scientific goldmine, with potential new markers or specific variations or adaptations that are potentially very useful, as let's say resistance to malaria or any specific diseases that are endemic from the region, they go unknown. And so that means that the AI systems will fail to identify these existing opportunities, slowing innovation for everyone. So AI can amplify bias, or it can help us fix it. It can help us detect and correct inequities if we have the appropriate tools that allow us to measure the representation of who is missing from the data sets. If we are able to measure how model accuracy varies across different ancestry groups. And we can even use AI for synthetic augmentation, where we could use generative AI, for instance, to balance representation when data are scarce. So for Brazil, Brazil has unique richness, and it also has a unified health system that makes it ideal for equity-aware artificial intelligence. So integrating the local data into pipelines could produce models that help us have a much better global positioning for Brazil as a leader in responsible AI, and better healthcare provision that is targeted for a very, very diverse population. So I'm going to conclude now. I hope that this was sufficiently illustrative to be able to convince you that we really need to fix this, because if we are able to reflect the data inclusively, then we'll have better diagnosis and treatment for all. This is not just good for the global south, it's also good for the global north, because having a much better representation and diversity will help us have better models that will improve not just specific treatments, but global treatments. I think that the fact that Latin America still remains to be properly studied can be an advantage, because there's a lot of richness that can help unlock discovery with global impact if we manage to have the representation accomplished in a fair manner. So I think that what the UK has achieved in terms of developing of infrastructures for biobanks, which is unique in the world, could be a tremendous opportunity for UK-Brazil collaboration in terms of having the sort of bridge between the amazing technologies that are being developed here and Brazil as a sort of gateway to Latin America and the global South. And with that, I'd like to thank you for your attention, and I hope that this was of your interest. Thank you.
Well, thank you, Dr. Manuel. That was great. That was such a clear and insightful talk. You definitely helped us to understand why health data equity matters and how this actually plays out in our real life, especially here in Latin America. So while you were speaking, I was thinking that having a more diverse data doesn't just improve I mean the health conditions of the population, but also can help public health systems to save costs in the long run, of course, by allowing us to have more visibility in ways and resources to deal with diseases in a more effective way, right? So I will now open the floor to questions. As Luciano mentioned, feel free to drop your questions in the Q&A section here. In the meantime, while the questions starts coming, I already have a few questions that I would love to get your thoughts on. And I loved your examples, the Yara one. I mean, this was a really practical ways to show us how this impacts our country. So the first one will be, you mentioned that we have fewer than 2% of global genomic samples coming from Latin America, right?
Yeah.
And we are training AI systems on this data. You mentioned that sometimes the researchers just discard the data of underrepresented populations. And as you said, biased data will lead to biased models that favor only the ones being represented. So what would it take, in your opinion, scientifically and maybe politically, I don't know, to make health data equity like a global priority, not just from an ethical perspective? I mean, should countries create more incentives to bear costs or maybe to share information that will be created? What's your take on me? I mean, the concern is obvious. While you were saying it, it was making total sense for me. But how do we incentivize and foster more room for this to happen more often?
So I think the main need that we have to find, and I definitely don't think that is difficult. We need to have a business case. And the business case is that, and I've been talking to governments, other governments in South America. There are, for instance, Peru, they've got gold mines, and it's a national resource that gives them a huge amount of income. So having a data bank that contains data from their native populations that is properly annotated, that has the sort of sufficient depth, that's a gold mine that could be used for pharmaceuticals to mine and then share the benefit with the local population. So again, we live in the 21st century where the actual oil of the 21st century is data. And Latin America has a tremendous untapped amount of diversity. And we just need to get to the governments that they're able to facilitate the necessary infrastructure and like we have done here in the UK, where it's basically public-private partnership. In the UK, we've had universities, policymakers, the NHS. For those of you who don't know, is the National Health Service, with the government and with some departments, all orchestrated to come up with a initiative that first will engage with the people that are underrepresented, letting them know how this can benefit not just them, but their children, their relatives, because, for instance, these data sets will help them if they have, cancer, to be able to see whether specific drugs would work for them or not. So I think there's a little bit of sort of social engineering that needs to happen. There's also, very importantly, engagement with patients, engagement with participants, so that they really see the value in having this diverse richness of data properly managed in a way that, rather than sort of selling it or making it accessible to pharmaceutical or big corporations, have a resource that is properly well managed, taking into account the interests of the country, with the appropriate legal framework, whereby the benefit of the research actually stays in the country. Because the other thing is that we don't want to have what we call helicopter research, which we have seen it many times. You have these researchers, they come, take the samples, and then the analysis is performed outside, and the local people have no control whatsoever on the data. So I think we need to have the appropriate regulatory framework, whereby the people whose data we are collecting is properly managed, is properly sort of safeguarded, so that the benefits are actually staying with the local economy.
I agree, and even from a protection of data of the ones having their information gathered and collected, this is really important. But I see the world covering this concern by enhancing the protection of data subjects. So I think we are in the right path. But I think now, with your answer, this is not only a political or an academic challenge. I think what I want to hear from you, maybe this is something that health professionals should also recognize and maybe advocate for. And so what skills do you think should be the most critical for the next generations of health data professionals? And especially if you think that universities are keeping pace with the shift.
If I understood correctly, so you're asking what would be in a way, the low-hanging fruit in terms of the next or the prioritization, or what would be the next most impactful actions that could be?
How can, like, maybe a quick win on how they should approach this. And the other thing would be if universities are preparing new professionals to think about this matter.
Yeah. Okay. So the first part. So what are the quick wins? So the quick wins are the illnesses that are most affected by the necessity of having genetic data. These tend to be rare genetic disorders. So patients that are born with congenital diseases. Most of them. Well, all of them, because you are born with that, so they are genetic diseases, and a lot of the time, many of them, they have not been properly diagnosed, and so these are the diseases that require most critically the need of genetic data. And what we find is that depending on the population, the diagnostic yield, i.e. our ability to confidently assign a diagnosis, is going to depend on the population. So if you are European, then you're going to have this diagnostic yield. And if you are a different population, you're likely to have a lot less. So we need to identify, first of all, what populations would have or would benefit the most in terms of improving the representation so that the diagnostic yield is sort of balanced with our current understanding that we have for Europeans, for instance. Then the other low-hanging fruit is the pharmacogenomics aspects, where we have, for instance, many drugs that happen for cancer that, depending on your genetic and your genetic makeup, they're going to work or not. For instance, for breast cancer, there's a drug called tamoxifen, which is the sort of first line on chemotherapy or drug for breast cancer. Depending on whether you have a specific genetic mutation, it's going to work or it's not going to work. So cancer is definitely a disease where we really, you really want to have the genetic test so that you can provide a proper diagnosis. Now, in terms of universities, I think Brazil is, compared to the rest of Latin America, is doing relatively well. The issue is that it's not performing at the level that we are here in the UK. But I mean, the UK is totally integrated this sort of high throughput approach in hospitals, and it's now become implemented as clinical routine. So if you have a rare disease or if you have cancer, you're most likely going to be sequenced, and you're going to have the infrastructure. So it's not just a question of the universities, really. It's actually the hospitals that you have the appropriate equipment. And then the other thing that is absolutely essential is that we stop sending the samples abroad, because what I see in Latin America is that basically, yes, we want to perform a genetic test, but then we send the samples to Germany, and then you're completely powerless. Somebody else is going to train their own workforce. So it's not just a question that you lose control on your data. It's that somebody else is actually, developing the analysis somewhere else. You want to, one of the big things that I always say about Latin America, we need to have, the samples need to be analyzed here. It can't, don't send them abroad. We need to have the appropriate infrastructure. And the first way to do that is to have somewhere centralized, in Lima, in Brasilia, Sao Paulo, wherever, where at least, it remains in the country. And therefore, it sort of is under the jurisdiction of your own country, so that you guys can make sure that you are able to benefit and control those data. Because, as I said, once you give the data away, then somebody else can do whatever. There's no way you can track what they're doing, and for sure, many of them are going to use it for their own benefit. So you want to make sure that you protect that as much as possible.
That was great. That was, thank you very much, Dr. Corpas. So I think I'll give the word to Adam here. Thank you very much for answering the questions, Dr. Corpas. And Adam, the floor is yours.
Thank you very much. Thanks, everyone. Indeed, I'm mindful of the time here. I'm sure we could have carried on for a few more hours with Q&A with such an exciting topic and fantastic speaker, but we do have to close out for today. Before that, I will hand back over to Dr. Manuel for closing thoughts.
Well, my closing thought is that we really need to stop sort of thinking less of ourselves. I think Latin America has everything it needs. I think it's about time that we perform any collaboration as equals, not as inferiors. We are equals, and this is about synergies. It's not about that sort of old science where somebody had the edge. I think that doesn't figure in my And I just want to basically say that you guys have a tremendous untapped potential. And I believe that you will, I think, 600 million people. I mean, if we are able to sort of coordinate a little bit more, we can have tremendous weight and put back Latin America in the focus of precision medicine globally, which is where it deserves to be.
Perfect. Much obliged, Dr. Corpas. It was great having you with us today. It's a real honor for Britcham. Awesome stuff. I also thank the audience for joining today and everyone tuning in afterwards to the recording on Britcham's YouTube channel. We do hope it's been a fruitful and insightful event for everyone. I invite everyone to subscribe to Britcham's YouTube channel and share the link to the recording of the webinar. Britcham's upcoming events are available on the website www.britcham.com.br. I wish everyone a great rest of the day and great week ahead. Thank you all.